Good evening, everyone. Welcome to tonight's webinar. This is our first webinar of the year, so glad you guys could join. I think there's only a couple of attendees tonight. Hopefully we'll have some more folks join us, but even still, I think hopefully you'll find it useful. Tonight, we are going to work on caseless construction. So certainly if you have any questions regarding caseless construction, I'm going to go over some examples with you guys so you can have a chance to see what looks good and what maybe doesn't look so good. And I will also go over some general recommendations. So having said all that, let me unmute. So it says both of you are self-muted. So if you could unmute yourself, that would be great. Okay. Is it Delara?
Hi.
Hi, thanks for dialing in. My name is Dan Green again, as I said. Just generally, do you have any questions about caseless construction before we get started?
I watched a little bit of the webinar from the USB drives that they sent me. But I guess I have questions. You know, I always have difficulty deciding how detailed and how much detail to give or how much detail to leave out. Because
okay.
obviously anything that you put on your list, you may get a question about.
Can you hear me?
That's true. Yep, we can hear you. Is this Hirani?
Yeah, this is Sean Hirani, sir.
Oh, I'm sorry. Yes, I can hear you. Did you have any topics? I want to make sure I cover some of the questions that you guys have, which I'll ask for again as we go along. But anything in particular that you were worried about?
Yeah, I mean, I think whereas with OB and GYN, obviously you have to place every case in the 12-month period. So it's a little bit more directed and self-explanatory. Where I get anxiety and concerns is actually from what everyone else enjoys, but I find it more difficult, and it's taking me forever to do the case construction, is the office part. And the reason is it's 46 different topics and they're so spread apart. I'm trying to pick topics that are diverse, but I don't want to get myself in trouble. I was told you're not here to impress the examiner. You want to keep it simple. But there are certain topics that I'm a lot of the internal medicine, family medicine stuff with cholesterol, hypertension, management. I want to stay away from that because I don't know how far they can go. And so how do we pick our strengths and when not to pick our weaknesses? What's the best strategy there, sir?
Okay, great. We'll talk about that. And you bring up a great point about you guys aren't here to impress the examiners per se. And that's kind of when people get into trouble. Okay, so I'm going to leave you guys off mute because there's only 3 people on. Jorge, I'm trying to get you off mute as well. So it says that you are self-muted if you want to come off mute. And this way we can have a bit of a conversation. If we get too many folks on tonight, I will have to mute people just because we end up getting background noise. But let's get started. So let me see. I'm going to pull up and then show you guys my screen. So let me just enlarge this for you guys. Okay. So just take a look at this. And again, Jorge, if you want to be off mute, it says you're self-muted. So there you go.
Yes, hi.
Hi, thanks, great. So guys, if you're looking at this case list, what's your thought, just your general impression, looking at, let's say, patient 22?
It's too wordy.
Yeah.
Yep, it's definitely too wordy. I mean, so where I'm going with this, guys, I mean, do we care that her left ovary with infarction and benign cyst is 8 by 7.5 by 6? or that, and this isn't even the best example. I've seen people put like uterine weight 68.2 grams. Who cares? We want to try to make our list as reader friendly as possible. So a couple things about that. They're going to be looking at your list the night before your exam. I'm going to put you guys on, or actually let's try it one more time. So they're going to be looking at your list the night before the exam. They have to go through your, let's say, GYN section, if they're the GYN examiners, and 5 other candidates as well. So yours plus 5, and that's after doing 6 hours of face-to-face exams with the candidates during the day. So you can imagine it's kind of a long day for these folks. And if people have, difficult cases to read, or there's a lot of extraneous, unnecessary information, it really just makes it tedious for them. They will form an opinion of you based off your case list the night before. So if you're somebody that has, let's say, 40 hysterectomies and they're all under 100 grams for alleged pelvic pain, but there's no pathology, they're going to have an impression of you as an aggressive surgeon. So the next day, many of your questions will probably be related to, criteria for hysterectomy, and it'll be up to you at that point to try to right the ship, if you will. So, try to change their preliminary opinion. Many people have like a neutral case list the night before, so they're not, worried about it, meaning the examiner, but they're kind of open-minded about it. So I would encourage you guys to kind of keep that in mind. We want to try to make it as reader-friendly as possible. I'm going to just see if anybody have any questions about that so far?
Nope.
Okay. Couple things. How I like to do these, I like you guys to look at other people's lists to try to see if you can find out what the problem is. If you were the faculty person or the examiner, and somebody presented a list like this, what would your questions be? Or what would concern you? The reason I ask these things, if you can pick out the problems, you can identify them on your own list so that there's, so we don't have them problems repeated, for example. So Jorge, if you're looking at this list, anything jump out at you?
Well, the fact that they put the schizoaffective disorder, borderline personality, and asthma, I think that's a little bit too much information, and you might have, they might ask you questions about that, I guess.
Okay, that's fair enough.
Pathology.
Richie, anything that you see?
I just feel that I agree that there's a little bit too much information. It sounds like the patient desires permanent sterilization, and I don't think you need to include that you had counseled the patient on post-sterilization regret. I don't think you need pre and post-surgical breathing treatment for asthma. I just think it just needs to be more concise and straightforward.
Okay, good. Zishan, again, take all 3 cases at once, so you don't have to focus just on the first one if there's anything else you see with the others.
The surgical pathology, you want to show that you got the tubes, right? Because you're doing a laparoscopic either staphyloidectomy or some type of are they doing? Let me see here.
I mean, it looks like they're just doing tubules. I don't know if they're actually removing the fallopian tube.
Okay.
Yeah.
Yeah.
I mean, for those cases where you don't have a pathology, do you want to put intraoperative findings?
Not unless there's something really dramatic, that you saw. I mean, if you didn't biopsy something and you saw, like stage 4 endometriosis, you could put, grossly stage 4, endometriosis, for example. So you can, but you don't have to.
It's a concern that there's not counseling on LARCs and other forms of contraception on there besides surgery.
Okay. All right, so I'm going to add a few other comments here. So let's take a look at it, guys. And you guys picked up a bunch of good stuff. So looking at the first patient there, desires permanent sterilization. Fine. Seizure disorder complicating previous pregnancy. Okay, I don't have a major big issue with that being on there. It kind of gives a little bit more credence why the patient might be thinking. But the schizoaffective disorder, and borderline personality, that actually starts to get me to think, well, is this patient competent to make this decision? And that's something I wouldn't want to get into on the board exam. I mean, probably she is, but but who knows how bad her schizoaffective disorder is, and does she have a guardian? Do we need to get into that? So I would leave that off personally. The asthma, if there were complications that caused me to keep the patient overnight because related to the asthma, most definitely I would list it. Otherwise, so she had a nebulizer before and after. Again, if your list is doesn't have a wide breadth, so it doesn't have a lot of topics or a lot of stuff to discuss, putting the asthma on there is one more thing you can do to broaden it so they have other stuff they could ask you about. But if your list is relatively broad or normal, I agree with you guys. I probably wouldn't put that on there. It's certainly not critical. It's not like, she had some sort of respiratory, arrest or respiratory, major difficulty that required something, unusual. And it's not like you're hiding something like, oh, we had to, intubate her, again in the recovery room or some, major complication and that you would want to list if there were major complication, but otherwise, no.
Right.
So let's look at the second one. What's wrong with the second one?
Multiple desires, permanent sterilization. It looks like this provider only counseled this patient on one option for treatment.
Well, even worse, you're right. But the worrisome thing for me is there's no procedure listed. So why is she even on my GYN list?
Correct.
That's true.
So, and the fact that they brought out the vasectomy for this patient, but they didn't mention it for the first patient or the third patient.
Yeah.
As the examiner, guys, if you're the examiner, are you kind of scratching your head going, well, geez, I wonder if this doctor counseled these other two patients about, vasectomy for partner.
Well, it's also interesting that all these three patients, the two that got tubules were under the age of 30. So it seems like this person is very aggressive in sterilizing women.
Well, it could be, but then again, if the patient really wants it and they're counseled appropriately, I guess my point is, when you have a patient that comes to you for a tubal ligation, you're counseling whether they're 21 or whether they're 48. Your counseling should be the same, even though that 21-year-old is much more likely to have tubal remorse or tubal regret than the 48-year-old. But your counseling should be the same. Hey, this is permanent. It's not intended to be reversed. There are many other options which are equally effective, if not more effective, such as, IUDs and so on and so forth. So when you call out something that's different here, like the vasectomy for this patient, if I'm looking at this the night before, I'm thinking, well, geez, when this doctor talks to patients about vasectomy, they list it because, look, they listed it for the second patient. Therefore, they must not have even talked to the patient 1 and 3 about vasectomy because otherwise they would have listed it. So the point I'm trying to make really, guys, and this is the take-home message from this, one, consistency is critical on your list. If you write something down for a patient, like if you're writing down antibiotic prophylaxis for your C-sections, I don't usually recommend people doing that. I recommend they verbally bring it out because, again, it's one, I'm sure you took the patient's blood pressure, but you're probably not writing that down too, unless it's abnormal. If you leave it off for one patient, then it's like, well, what's going on here? Why did they do prophylaxis for all these C-sections, but these two they didn't? So consistency is very, very important with your list. Remember, you're not there to explain it to them the night before when they're looking at it. Any questions about this?
Nope.
Okay. Um, I think it was Zishan asked about office list and what cases to put on here. Well, remember, guys, they could ask, whether it's on your list or not, they could ask you the topics and the categories that come up, and they could even use your patient as a springboard. I'll just use this patient number that you see displayed on your screen. They could say, well, I see patient number 1 on there, desired permanent sterilization, but let's say instead of desiring permanent sterilization, she came in with urinary stress incontinence. How would you work a patient up for stress incontinence? It's like, holy cow, that's nothing like what I've got on here. The only thing that would be in common is she's 29 and a G1P1. So they can deviate, but you run a higher risk of deviation on your office section if your list is very constrained. And by constrained, I mean, let's say you have under vaginal disease or vaginitis or whatever the exact name of the category is, that's where people usually put things like yeast infection and what have you. I just reviewed a list this afternoon before I dialed into this, and the candidate had 2 yeast infections. One was 22, and I think nulliparous, and then there was a 26-year-old who was a G1. But other than the 4 years age difference and the 1 child, there was literally no difference between the 2 entries. So yes, by the letter of the law, she met the requirements by having 2 patients, not more than 2 in 1 category, but she didn't provide breadth to the list. They're not going to ask you about 2 yeast infections. It's just not likely. If she had, what would be preferred would be to have a yeast infection, maybe in a bacterial vaginosis or trichomonas. And if you wanted to make it even a little bit more interesting, how about like recurrent BV or recurrent yeast infection? Because it promotes, it's more likely they're going to ask you about that than somebody who comes in with an isolated yeast infection.
So would it be fair to say that instead of having 20 topics times 2, 40 times 1, or it doesn't, the advice I was given is, look, just pick 20 topics that you like, double up on each of them, and then you're done, because 40 is a max. What would you say is a better approach?
Well, it depends. If you pick those 20 topics, again, if you have 2 routine yeast infections, I'd say that's a waste of a case. I'd rather you actually only have 39 cases than have 2 yeast infections. It's not that it's wrong to have the 2 yeast infections, it's just it doesn't add anything. I see it all the time with like well woman visit, the first section under preventive care. They'll have somebody who's, let's say, 26 and somebody else who's, let's say, 35 or 38. They're in the same age band, so the recommendations pretty much are the same for them. Better to have somebody who's in their 20s and somebody who's in their late 50s or 60, and then now all of a sudden you have a little bit more of an interesting choice for them to ask you. There's an increased chance that they're going to ask you about one of those patients versus, again, somebody who's 20 or 24 and somebody who's 30.
The other thing was there's certain things that I'm can you hear me?
Yeah, I hear you.
Yeah, saying there's certain topics, for example, that I'm almost a little concerned for them asking. And the thought I had was, why not address it with the case rather than leaving it blind and then they bring that up themselves, because that could be much worse. And I'll give you an example. I had done an office hysteroscopy, and a patient just had class 3 obesity, having irregular bleeding. I was going to do a hysteroscopy EMB, and it found out that she had what appeared to be a septation. Well, that can turn that into, is that an arcuate or is that a septation, or how it's a bicornea? I'm scared of those topics. So is it better to address it and talk about it as a case, or not at all?
Well, so the bottom line is, if you put that list case on there, you're going to need to know all the things that you're afraid to address. It doesn't 100% preclude you from having to know it if you don't put it on there. It just means that you better be as, if you're putting it on there, you're almost inviting them to ask you about it. So you guys should be a master or, close to a master of all the cases that you have on there. So let me give you another example, Zishan. This may help to clear it up for you. Primary amenorrhea is like, I hate that subject. I mean, every time I always had to look it up.
Right.
It was the one thing I went into the boards actually studying. I had taken the notes with me, to look at right before I went to check in. And doggone if they didn't ask me about it, even though I didn't have a patient of primary amenorrhea on my list. And I could tell them the 17 causes of primary amenorrhea at that time. By the time I hit the airplane that afternoon, I couldn't tell them more than the 5 I could tell you right now. But my point is, it didn't preclude them from asking me, but I would have never invited that, because that's something I know that I struggle with. And, if I put it on there and I can only give the 5 things I can give now, that looks bad. If they ask me out of the blue about primary amenorrhea and I can, give the 5 things, well, it doesn't look great because I'm still 12 short, but, it's not like, oh, I had this patient and so therefore I should know this because I've had to take care of it. What it's saying is I had a patient like this, I had to take care of it, and I still don't know what the hell I'm doing. Does that make sense?
It makes a lot of sense. So I'm not going to.
Yeah, it makes sense.
So guys, take home message number 2. So consistency is critical. So take home number 2, just as Zishan alluded to, do not find the most interesting case, in your practice to list on the list. I can't tell you how many people, who we do mock orals in the fall and they go, oh, I wish I hadn't put this patient on my list. It's like, I put it on there because I thought it would be really interesting, but now I've had to spend 2 hours just learning about, this rare genetic condition. And it's like, yeah. So don't find the most interesting case, but do try to mix them up a little bit, as I said. So, not 2 yeast infections, for example. Not 2 abnormal uterine bleedings, both with fibroids. Not to say that you couldn't have 2 AUBs on your list. With one might be fibroids, the other one might be fibroids, but the other fibroids may be under office surgery. Maybe you did an office hysteroscopy and removed it in the office. I mean, I'm stretching a little bit there, but I think that I think you get the idea of what I'm suggesting, right?
Right.
Okay, anybody have any questions so far about what we've talked about to this point?
No, really.
Okay, does anybody have a problem with this next case that's being displayed?
Yeah, why did they wait to 42 weeks to induce labor in the patient with gestational diabetes?
Exactly. I mean, it's like, hello. Now, there's not a lot they can do about that if this is what really happened. But one thing they could do to help mitigate it just a touch would be to put gestational diabetes well controlled, maybe. Or maybe there was something else compelling about this patient, like she was not compliant with appointments or something, so she missed her 40-week appointment or 41-week appointment or what have you. So little things like that can help to soften things. Again, obviously assuming it's the case. There's one other problem with this case as it's displayed. Anybody else see it?
The section was for failure to progress, but we have failed induction.
Okay, so what's wrong with that?
Well, it should say primary cesarean for failure of induction, or giving consistency. They need, they both need to be similar.
So is failure to progress different than a failed induction?
Correct.
Yes, that's exactly right. Sorry, go ahead, Richie.
Sorry, I don't do obstetrics, so this. Can you explain that? Sorry.
Sure, no worries. So if somebody is a failed induction, first of all, it wasn't a very long failed induction because she only had 3-day length of stay, as did the baby. But putting that aside, a failed induction, if you go to induce somebody and she doesn't deliver vaginally, that's not necessarily a failed induction. it would be a failed induction if you were unable to get her into labor. So if you were unable to get her to, let's say, 6 centimeters, then it's a failed induction. Failure to progress, which is a slang term and shouldn't be on there in the first place, it should be arrest of labor, arrest of active phase of labor, whatever. It means that the patient was 6 centimeters. She had adequate contractions for 4 hours, generally with an IUPC, or 6 hours without adequate contractions. So you can't have a failed induction that is, again, what the slang of failure to progress really should be, meaning arrest of dilation. They're mutually exclusive, in other words.
So should you just put primary section under delivery or postpartum, or?
No, that's a great question. So this would, anything that occurs up until the time you write admit to labor and delivery, so until you write that official admission order, goes in the antepartum. Once you write the admit to labor and delivery, anything that happens in the labor course from that point all the way through the postpartum goes in the delivery or postpartum column. So the failed induction, if that's what it was, is actually listed correct where it should be. The failure to progress, wouldn't be listed there anyway. I mean, let's call it arrest of active phase. If that were the case, that should actually be in the delivery postpartum complication column. So the procedure should just say primary cesarean section. But really, since she's failure to progress, assuming she got into active labor, the failed induction shouldn't even be on there. And as the examiner, if I'm looking at this the night before, I'm saying to myself, this doctor doesn't know the definitions of these basic terms. So I already start to have some concerns.
Right. Now, can you put just in the delivery or postpartum complication, arrest of labor and the operative procedure primary C-section, or you have to put primary C-section for arrest of labor again?
No, and you shouldn't list it twice, Jorge. So this would read gestational diabetes, and then the delivery postpartum would say arrest of active labor or arrest of labor, and the procedure would say induction of labor, IUPC, assuming you had one, and then primary cesarean delivery. So you need the induction. You would need the induction because she was induced. So that is something you have to list. Now, again, sometimes people put, prostaglandin or Foley bulb, and then they put in Pitocin and induction. Too much stuff. I always tell people try to be as generic and high level as you can because it promotes simple questions. So I would, if I actually did cervical ripening on this patient, I would probably say cervical ripening, induction of labor, IUPC, primary CD. That's how, I would list it, assuming that she wasn't favorable and I had to do cervical ripening. If she were favorable, I would just put induction of labor, but I wouldn't put Pitocin or any of that stuff. I mean, what else are you going to induce the patient with? It's going to be Pitocin 99% of the time, but make sense?
Makes sense.
Anybody have any questions on this one? Okay. Richie, you had mentioned you had asked me a question at the beginning. Can you repeat it, please?
I'm not. I don't remember.
Look, I'm old,
question.
Well, you were talking about, general question about your case lists.
Oh, just like how much detail to go into and what to leave out, what to put in, like, is omitting too much information bad, or, like, I just don't know how much detail to go into.
Well, you want to have enough that the examiner can put together kind of the whole story, not writing, in narrative. So you're not, so I admitted the patient and sent her. No, we're not doing that. But you want to have enough information when, if they go to look at the case the night before, it's like, oh, she had this situation, so these are the tests she got. For example, when we get to office, I usually tell people, for the well woman, instead of listing, Pap, mammogram, referred for colonoscopy, lipid tests, hemoglobin A1C, TSH, I tell people put age-appropriate screening. And if you feel strongly about it, you could put age-appropriate screening and labs. But I tell people not to list the specifics, because listing the specifics takes away one of the questions the examiner can ask. A similar example, if you have a patient with a postpartum hemorrhage, I'd much prefer you to say uterotonics than say, well, Pitocin, Methergin, Hemabate, Cytotec. If you start listing all that kind of stuff, it takes away questions that they can answer. So then they're going to get to the harder questions straight away.
Gotcha.
Same thing with shoulder dystocia. Don't list every maneuver that you did. That's something you verbally want to bring out. So just be generic about it and put shoulder dystocia maneuvers. First of all, it'll make it more concise. Second of all, it gives you something to talk about.
What about for like this example for pelvic pain? Would you just say pelvic pain? Would you say acute pelvic pain, chronic pelvic pain?
Also, yes, I would distinguish between the two, because, of course, the differential is going to be different and your management's going to be different. So, acute versus chronic, I would definitely want to distinguish.
Gotcha.
Does anybody have a problem with the way this is listed?
Yeah. The fact that, first of all, they did a TH for the uterus that is 160 grams.
Yeah, so that's certainly what's up with that? Why did they do that, especially in a para 4?
Yeah, and the other thing is there is no mention of what other treatments or medical treatment they try for pelvic pain or menorrhagia.
Yep, there's nothing, either failed medical management or desired definitive treatment. Those are good catchphrases to put in. You don't need to put both in, but for any given case. But again, the list I reviewed earlier, this person had a lot of hysterectomies on there, and again, she was very brief with how she listed things. So on the one hand, I was, I congratulated her, but she was too brief, because it would say something like abnormal uterine bleeding, endometrial biopsy negative, hysterectomy, and the uterus weighed 100 grams or something. And it's like, hello. I'm sure that's not what really happened. But again, when I'm looking at the night before, what I'm thinking is, boy, this woman is extremely aggressive in how she approaches patients for surgery, which may not be the case at all, but the way it's listed, it says that. So this would be pelvic pain. I would think that we would want to have, failed medical management. Certainly there's no endometrial biopsy. Now you could say to me, well, hey, she's only 38. Well, I would say back to you, yes, but if her menorrhagia is so bad that she's having a hysterectomy at 38, shouldn't we, do a pre-op sampling? And the other thing that concerns me about this is where this high-grade squamous intraepithelial lesion come from. So in that situation, if you had a case like this, you would want to, normally I would say never to list the PAP unless you're talking about LEEPs or cold night cones or something related to cervical dysplasia. In this case, I would definitely put, PAP up to date, or PAP within normal limits, because this is something that's unusual. And if you guys have listened to any of Alvin's, talks about caseless construction, he talks about exclamation points and things of that nature. This would be a situation where you could put an exclamation point. I'm not as big an exclamation point or emboldening kind of thing as Alvin is. Once, maybe twice on a list, and it should be something that's really, really unexpected. Okay.
I have a quick question. What about in the pathology? If they're using a nomenclature, for example, simple hyperplasia or without atypia, instead of using EIN, what do we do with that? If the pathologist did that, do we just still
Yeah, good question. There's a few ways you can approach that. You could put simple hyperplasia with atypia, in lieu of EIN, and you could put it in quotation marks if you wanted to. The other thing you could do is you could put, how they listed it and put in parentheses, EIN or endometrial intraepithelial neoplasia. And the third way you could do it is just transfer it, interpret it basically to EIN. Any of the three are fine.
Okay. For the hysterectomy cases, do you recommend to put the ultrasound findings in terms, let's say, if you're doing a hysterectomy for fibroid, just list the biggest fibroid and the size of the uterus, or not even?
Excuse me. Sorry. So for the, excuse me, 1 second. For the ultrasound listing, so first of all, I wouldn't use the term fibroids. I would say leiomyoma. It's one thing to verbally mention fibroids. It's another thing to have it in writing on your list, because remember, you have the luxury on your list of, it's like submitting a paper. There shouldn't really be many typos because you have the luxury of reviewing it. In the case of the ultrasound, I wouldn't, if you're going to list the dimensions, I would say, uterus 15 centimeters. I wouldn't put 15.6 by 6.9 by 9.3. First of all, round it up. Don't go to the decimal points. The only time millimeters really are relevant is if you're talking about endometrial thickness. And even then, I would round up the whole number of millimeters, not like, 6.3 millimeters or something of that nature. If you have fibroids, and there are multiple fibroids, I would just put multiple myomata, largest 10 centimeters.
Okay.
So I'll gross you guys out. When I coughed, a bug flew in my mouth, and I think I swallowed it. Sorry about that. I mean to cough in your ear, but I was like, What other questions do you guys have? So I've noticed so far this year, a bunch of folks are putting on their list BTL, when they may in fact mean salpingectomy. So I'd be careful about the BTL because, bilateral tubal ligation. So that could be, using bipolar, it could be using a clip, it could be removing the whole tube. So you really want to try to be a little bit more specific if you're going to abbreviate the BTL. You can still abbreviate the bilateral, B/L. I would just say salpingectomy if that's what it was. And if it was tubal interruption, then, so be it. Do try to make sure that your hysterectomies for any bleeding problem have endometrial biopsies. Assuming you did it, your arrest disorders, not so much your arrest of descent or second stage arrest, but your arrest of dilations. Again, assuming you had IUPCs, really should have IUPCs listed. Richie, I muted you because of the background noise. So if you want to comment on anything, just raise your hand, if you don't mind, please. Take a look at this one that's displayed. I mean, I think you all would agree this is a pretty easy one to read. So if you're having to look through this the night before, this is not tedious in terms of reading. Remember, your ovarian cysts, they want the dimensions. They want the size. So you see how this one says bilateral ovarian cysts, 3 centimeters. That's good. The one above it says 5.5. Personally, I would have rounded it up or down. So I would have said 5 or 6, but I wouldn't have left it at 5.5, just because it really doesn't matter. And when you get to pathology, since we're talking about how to be brief, you can put if you did a hysterectomy, uterus, 158 grams. Cervix, endometrium, fallopian tubes - benign. If there's a fibroid there, you can put, myoma - benign. So you don't have to put, I was looking at somebody's yesterday and they had like squamous metaplasia and no dysplasia of the cervix, but it was all this, a lot of verbiage that was basically came out to as benign. And who cares? These are not things we would, address or treat. So you want to kind of be mindful of that when you're trying to put your pathology in. So let me pause there and see if anybody has any questions. Okay. So remember, guys, go ahead. I'm sorry.
Yeah, in the patient number 18,
did I just click out of the one?
I believe so.
I'm sorry. I think I may have closed out of it altogether. I did. So yeah, what's your question though?
I think you're in patient 18. My question was, let's see.
Give me a minute. I'll see if I can find it.
Sure.
Was this it? Yeah.
Yeah. So I thought like the pelvic ultrasound in standard treatment shouldn't be like on the preoperative or admission diagnosis, like the information and then just the treatment for hysteroscopy DNC.
Yeah, so that's true. So the pelvic ultrasound for patient number 18 would be normally recommended to be over under the pre-op diagnosis. You're absolutely right.
Okay.
Same thing with the failed medical therapy for patient number 17 and 16. Those really should be over under the pre-op. Good call there. Okay, so a couple other pointers I want to give you guys. Remember that a patient should only be listed on your list. Richie, I'll get you off mute in 1 sec. I just clicked it, so if you want to get yourself out, there we go. A patient should be on your list only one time. So if you, did the delivery and then, you did an interval tubal ligation, she really should go on your OB list, and you just skip a line and you would put, 6 months postpartum laparoscopic tubal ligation or laparoscopic self-injectomy or something of that nature. So she can only, again, be on one time across all 3 sections, not once on each section, but one time across all 3 sections. Richie, you had a question?
Yeah, so the same patient that he had a question about, number 18, you don't have to go back to it, but the procedures were ECC and EMB, and it was a GYN surgery list. Should we be putting those on the GYN surgery list?
Yeah, so this actually, this EMB, really, assuming it was done in the office, really should be on the pre-op. The hysteroscopy DNC is why the patient's on the GYN list. Okay.
So I'm assuming the ECC, EMB would you put that in diagnosis preoperative or?
Yeah, so really for this patient, what I would write, let's assume we did the endometrial biopsy in the office, excuse me, I would put EMB dash benign, or in this case, EMB endometrial polyp dash benign. And then the hysteroscopy DNC, probably had its own pathology, like the ECC, because you probably did a fractional DNC. So the ECC, you could just put benign. You don't need to put negative for dysplasia. It's more verbiage, but I mean, it's not wrong by any means, of course. And then if there were anything on the endometrial curettings or on the hysteroscopic resection, it would say, fragments of endometrial polyp. Let's say there was some residual, and that would go, of course, in the pathology.
Okay.
But you're right. The EMB, assuming it was done in the office, really would go over in the pre-op.
Okay.
All right. So, you saw, I should go back to it one more time. Look at this list one more time from just, high level, forget what's written down. Isn't it easy to read? I mean, not only is it not a lot of material, but look how they've got one diagnosis per line. Here where it doesn't fit, they've set it off where it says the desires permanent sterilization. So there's a space between each diagnosis. But even if you don't space it between each diagnosis, at least having one diagnosis per line and not putting like pelvic pain in the comma, postmenopausal bleeding, and a whole bunch of other stuff, that's when it really gets monotonous and hard to read. So you want to try to have it, spaced so it's easy to follow. Yeah, go ahead. Sound like somebody was going to say something. Okay. So definitely try to space your patients. Situations, let's say a patient has a complication, but you don't see the patient for the complication, one of your partners does. So let's say you do a C-section for arrested dilation in a patient with arrested dilation. Let's say she comes back 4 days after discharge with preeclampsia with severe features, and she's admitted and given seizure prophylaxis. So you would list the complication, and then you could say readmitted, times 4 days, and you, in parentheses, I would put by colleague, or by partner. Some people have, are laborists or they're on call and they see a whole bunch, they see patients that they didn't take care of prenatally. So I've seen people, concerned about that, and they're like prenatal care by, colleague or partner. If they did something before you assumed care for the patient that is different than you would have done, it is important to note that. If they didn't, if they managed the patient in the antenatal period exactly how you would have, then you don't necessarily need to call out that distinction.
Okay, I see.
Does that make sense to everybody?
Yeah.
Okay. Try also not, well, you can't actually have a case extend over more than one page. Oh, a couple other things. Sometimes people leave out the type of delivery. They've got all this stuff, but they never mention that the patient had an SVD. So make sure all of your patients that delivered have a delivery listed. The other thing is you want to make sure they have delivery. I'm sorry, I lost my train of thought for a second. Well, that would be the big thing. It'll come back to me in just a second. Gray areas
I have a
in
question
terms of
about
things
that.
That's a good question.
Go ahead.
Sorry. So, for listing down the delivery, what if I admitted a patient who was like 15 weeks and she was admitted for pyelo, and that's one of the obstetrical categories, but yet I didn't do her delivery?
Yeah, so you could still you should still list her. I mean, you have to.
No.
List her
I mean, like what? So you said to put what type of delivery they had. So is it okay if I just leave it blank?
Yes, absolutely. So it would say gestational age 15 weeks. Pyelonephritis, IV antibiotics, length of stay 3 days. Something of that nature. Now, where it gets a little bit trickier though, Richie, is let's say you admit a patient at, let's say 32.5 weeks with PROM. So you give her latency antibiotics, you give her steroids. So you do the basic initial workup, but she doesn't become infected and she doesn't deliver until she's induced at 34 weeks, which is not by you.
Yeah.
So that gets a little bit trickier, and you can put, what you would put is you'd put what you did, the 32.5 weeks, the steroids, the whatever, the latency antibiotics. And then you could put delivered by, in the procedure treatment, delivered by colleague at 34 weeks.
Okay.
Or SVD at 34 weeks, parentheses, by colleague.
What if you don't know what happened to them? Just leave it blank.
Then just leave that. Right. Now, you bring up a good point. Be careful with this not knowing what happened to the patient. And by that, I mean, if you may have patients that had, I think one of you was talking about EIN before. Let's say you had a patient that actually, you refer to oncology because she has endometrial cancer. That's fine and appropriate, but they're going to want you to not put in writing on your case list, but they are going to want you to know what happened to the patient. So you don't need to know that, hey, she went to the oncologist, she had a hysterectomy on day 2, she had a respiratory event on day 4, she passed flatus, and you don't need all that detail. What you need to know is she had a staging laparotomy. She was stage 2A. She ended up having adjuvant radiation, and her prognosis is X.
What if you don't have access to those records? Like, let's say you work for a hospital and the patient gets referred to like a outpatient oncologist. You'd have to like track down that information, right?
Well, again, they're going to look for the problem with that is they want you to they want to know that you kind of, it's going to sound crass, cared enough about the patient.
Yeah.
Right. Again, they're not going to expect you to have, pull the op notes and pull the, record. Oh, she had an ileus on day 3, and they kept her an extra 3 days. Nothing like that, but high level detail.
Okay.
Does that go for the same for the office in that section that says reproductive tract cancers? If we see them and refer them, like in other words, someone has a cervical cancer and we refer them out to a gynonc, even in the office section, we need to know and put in that office section what had happened.
Yeah, so you wouldn't list. I mean, some people do this, and it's not absolutely wrong. You could say referral to GYN oncology, forward arrow, stage 3B ovarian cancer or whatever, or you could just say referral to GYN oncology. And if you're asked about the case, then you could say, yeah, she saw the oncologist, and they did a staging laparotomy, and this is what she had.
Okay.
Again, it's kind of like closing the referral loop. It's they may never ask you about it. The problem is if they do ask you about it and you have no idea, especially if it's more than one patient per section, it looks like, oh, well, I sent them off, they're not my problem anymore. And I know that sounds cold, and I'm sure that's not how you guys feel, but you get the appearance. Not like you can debate them in the middle of the exam.
Right.
What other questions do you guys have? Okay, so only 2 patients per category will count, even though you've got to list all your patients. So if you have, 10 repeat C-sections, only 2 of them would count in the category towards your required 15. But obviously, you still got to list all of them. In terms of listing things, if somebody has a 3-centimeter cyst and let's say they're 30 years old, even if it's complex, I always love when people have tumor markers on their list. It says tumor markers normal. That would be something I probably would not list on my list. And again, if they asked you during the exam, did you get tumor markers? I'd be honest. I would say, yes, I did. But I wouldn't volunteer something like that because it's really not necessarily indicated or recommended at that point. Again, it's one thing if you have somebody with a 15-centimeter cyst, especially who's postmenopausal, but do try to be careful when you have your prior C-sections. So even though they're under repeat C-section, it's always helpful to put prior CD times 1, 2, 3, whatever. And if you offer them a trial of labor again and they decline, I would put prior CD times 2 declines TOLAC, TOLAC, or desires repeat, declines VBAC. Any of those things are fine.
Okay.
What other questions do you guys have? else?
Is it, I mean, when you go through a case list, roughly, is the argument that each case is roughly about 1 minute? Is that sort of how that works? For example, like
Oh, you mean during the exam?
Correct, sir.
Yeah, no. So what's going to happen is, as I mentioned, they're going to look at your list the night before, and they're going to pull somewhere between 5 and 7 cases from your list that they're going to ask you stuff about. And they're not going to say, hey, tell me about patient number 22. They're going to say, I see patient number 22 had preeclampsia with severe features. What are your criteria in making that diagnosis? So, then you would go through what constitutes preeclampsia with severe features. And you can relate it back to the patient. You could say, well, here are all the different things that would qualify as preeclampsia with severe features. And this particular patient, she actually had HELLP syndrome. So that's what brought her into the fold. So you can relate it back to the patient. But they may ask you general questions like that. Or they may say to you, I see that patient number 22 had a primary C-section. I don't see that she was, she received Pitocin or that there was an attempt to induce her. Why was that? Well, she had HELLP syndrome. Her platelets were falling, seemingly from every hour or two. And we were concerned that, she needed to be delivered imminently or immediately. You see what I'm saying? So the questions are going to be, why did you do whatever you did to a certain patient? Or they're going to use the patient as a springboard for the topic typically.
You're saying about 5 to 7, and that from all our cases, essentially.
Right. So if you think about it, they have 30 minutes, 25 to 30 minutes to cover these patients, and then the other half of the hour is spent on structured cases where they'll actually give you the case. It's like case of the day, we call them. So it may not be anything on your list, or it could be something in common on your list as well, but they won't be using your list as the springboard. They couldn't really go through every single case. Structured case, you mean?
Yeah, for the case of the day, is it just one case, or can they go through multiple?
They need to get through at least 5 of them.
Gotcha.
So again, that'll be a 5 to 7 as well. But their goal is to get through at least 5. I mean, it would be unfair to ask them, ask you one case if it's something that you really don't know, and it's not a pass-fail thing. I mean, there's certain topics that are pass-fail. If you don't know how to manage a postpartum hemorrhage, that's a pass-fail question. Shoulder dystocia is a pass-fail question. But primary amenorrhea is not a pass-fail question.
Right. What about in terms of the newborn? I have a patient that she was out of town. She was, I believe, between 28 to 30 weeks. Went into preterm labor and, developed preeclampsia with severe features. Long story short, she delivered, baby was fine, and then at day, I believe 7 to 7 in the NICU, developed some intraventricular hemorrhage, and it was transferred to a higher, facility, and unfortunately the baby, died at 10 or so. How much information are they going to ask you about the baby?
So I'm sorry, Jorge, I'm not 100% sure I understood all of it. Did you do the delivery?
Yeah, I did it. So one of my partners sent me the patient the night before, and when I came, the patient was already in preterm labor and developed preeclampsia with severe features. The delivery, other than try to expedite it because of the blood pressures, was a vaginal delivery, and the APGARs and the gases were fine. Just baby developed this bleeding, I guess, because of prematurity, and the baby passed day 10, I believe, in another facility. But that's all the information I have for the baby.
Yeah, that's pretty much what you'll need to know. I mean, again, they're not going to expect you to be able to say, oh, well, the patient was transferred to, University of my state, and On day 1, the baby had feeding issues. On day 2, the baby was acting funny, so they got a CT of the head, and they're not going to expect, a day by day, a blow by blow. But, unfortunately, the baby passed away on on day of life, 10 from an intraventricular hemorrhage due to prematurity. That's what they would expect you to know.
Okay.
All right. Any last questions before we wrap up?
Not from my
I'll just
end.
show you one more that's, I think, displayed here. You see the cefazolin that this person wrote for their C-sections. I mean, it really doesn't add anything, the antibiotic prophylaxis. Now, having said that, if somebody's GBS positive, then by all means, I always suggest that people put GBS prophylaxis. And if somebody has chorio, then I would, of course, list IV antibiotics. But this is just prophylaxis for the C-section. And that I would not recommend listing. Just like I wouldn't recommend DVT prophylaxis unless there's something exceptional, like the patient either has a thrombophilia, she's had a DVT before, or let's say she's, morbidly obese, for example. You can also see here the prior CD. This person just put prior CD. And, we don't know whether it's 1 or 2 for this patient number 47. For patient number 50, we don't know if it's, 4 or 5. Actually, this gravident parity is probably incorrect. But you can see why it's helpful to list the number of them. And this person, even for the prior CD times 1, it doesn't say anything about TOLAC, that they counseled the patient. So that's why I wouldn't put, mode of delivery counseling. I would just put either declines TOLAC or desires TOLAC or VBAC, either one.
And
Okay.
do you have to put the TOLAC counseling even if you didn't do it, if it was one of your partners?
So, again, I'm not 100% sure what you mean. I got the partner part, but do you mean that you did the C-section, or which part did you do?
Yeah, so I did the C-section because, she was, when I was on call, she was 39 weeks. But, through the prenatal care, she was counseled by one of my partners about TOLAC and versus repeat C-section, and the patient declined TOLAC. So she was scheduled with me on 39 weeks.
I understand, but did you ask her if she wanted the C-section? I'm sure you did. You got informed consent, I'm sure, right?
Yeah, but just the day of the delivery, which was the first day, I met her, so I asked her, so I see that you were counseled about TOLAC and you don't want to have that, you want to have a C-section, and she said yes. So she basically...
Yeah, no, I wouldn't put by colleague. First of all, you mentioned to her because you got informed consent. Second of all, your partner counseled them, so the patient was counseled. You're not saying, you know what I mean? I mean, since most of you are practicing in group practices, it's unlikely that you're going to see an OB for every single visit, if she comes in regularly and she's, registers early in the first trimester. I mean, it's just not likely that you'll hit all 14 visits or however many she has. So that's fine. The point is she was counseled and she declined.
All right.
And they're not going to expect you to remember, oh, I did the counseling on this patient versus my partner did the counseling, that kind of stuff.
Okay, I see.
All right. One last thing, where you guys have on your OB list chronic hypertensives or diabetic patients, I do suggest putting diabetic management or hypertension management. Again, rather than listing every single thing that involved. In other words, for diabetic management, if she's pregestational, I'd rather you not list, ophthalmic exam, EKG, antenatal surveillance starting at 32 weeks. I'd rather you put diabetic management, which could encompass all that, 24-hour urine, all that stuff. So again, that's a way to kick it up to a more general level without listing every single thing that you did.
Okay, I see.
All right, so I'm sorry I kept you guys a little over time. Or any last questions before we conclude?
Nope.
Well, thank you guys for dialing in tonight. I hope you found this helpful, and I wish you guys the best of luck as you go to prepare your list. I'm sure we'll be talking at one of the other webinars during the course of the year. So have a great evening and good luck.
Thanks. You too. Bye-bye.
Thank you.
Thank you. Good night.
Night.